Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose. In continuity with the previous lecture series, today we'll be dealing with another very interesting topic, that is Myasthenia Gravis. It is one of the common disorders which you see due to myoneural junction disorder, and you are very much aware of this person, that is one of the best actor in our Hollywood industry, Bollywood industry, sorry, that is Amitabh Bachchan. He was also suffering from myasthenia gravis. So we'll be dealing with a disorder of muscle, mainly myoneural junction or neuromuscular junction. We call that as myasthenia gravis. We'll be discussing under these common headings. We know very well myo means muscle, asthenia means weakness, and gravis means severe. So whenever you get a muscle weakness which is quite severe, we label that as myasthenia gravis. So it is also called as a severe muscle weakness. If we want to define, we can define myasthenia gravis as an autoimmune neuromuscular disorder leading to fluctuating muscle weakness and fatigue. Or we can say a disorder of neuromuscular junction which is due to presence of antibody to acetylcholine receptor at neuromuscular junction, and because of this particular defect the person gets weakness, fatigability of cranial muscles, limb muscles, and respiratory muscles. That will be peculiar in a variety we call as a generalized myasthenia gravis, and particularly extraocular muscle, orbicularis oculi, and levator palpebraris superiorus will be involved in ocular variety of myasthenia gravis. 15% of the cases are belonging to ocular group, that is one of the most common presentation in myasthenia gravis. So myasthenia gravis is a neuromuscular junction disorder where person gets skeletal muscle weakness. This is because of an autoimmune disorder where there is a formation of an antibodies which blocks or destroys nicotinic acetylcholine receptor, which is present on postsynaptic plate or postsynaptic membrane present on muscle, and that's why it is called as neuromuscular junction disorder, and it is characterized by abnormal fatigability of voluntary muscles, the muscles which we use repetitively. So voluntary muscles on repetitive activity, and person recovers by rest. This is a very peculiar condition. Electrophysiologically, decremental response to a repetitive stimulus by a single fiber electromyography, and there is an improvement in the muscle weakness. So muscle power improves by administration of acetylcholine, or we call anticholinergic esterase drugs, and good number of time it is associated with abnormality of the thymus because it is basically an autoimmune disorder, and there is a presence of a circulating antibody to acetylcholine receptor, but we label that as nicotinic acetylcholine receptor, and this is a complement mediated damage to the receptor because of autoimmune mechanism. So this will be the entire other portion of labeling a person to have a myasthenia gravis. Indirectly, this is what we call as a pathophysiology. So it is a disease characterized by progressive weakness and exhaustibility of a voluntary muscle without atrophy, and there is no sensory disturbance, and this particular is because of autoimmune disorder where nicotinic acetylcholine receptor is being affected, which is present on postsynaptic membrane that is over the muscle. This particular will produce muscle weakness, which is worst with activity, and it improves with rest. So person will say that when I wake up, I feel fine, but at the end of the day, I feel weak. And sometime from repetitive movements, person will start developing muscular weakness, like repetitive movements, particularly say like chopping or cutting the vegetables, etc. The common terminology which can be utilized, or we call types or classification, the words which are being utilized commonly, we call autoimmune, depending upon the etiology, neonatal, congenital, and drug induced. Or we divide into two big groups, Myasthenia Gravis and Lambert-Eaton syndrome. Lambert-Eaton syndrome is due to defect in presynaptic end of axon, while Myasthenia Gravis is a postsynaptic membrane where there is a damage to acetylcholine receptor, we call nicotinic acetylcholine receptor, and that is being divided into two classical variety, we call ocular variety and generalized variety. So we come across some variety we call as an ocular myasthenia gravis, congenital myasthenia gravis, and neonatal myasthenia gravis. These two, that is congenital and neonatal, are rather uncommon, while ocular variety accounts for around 15% of the myasthenia gravis group. Now there is an Osserman classification of myasthenia gravis, which is being put forward by American Clinical Classification, which is dividing that into class 1, class 2, A, B, 3 is divided into A and B, 4, A and B, and 5. So just we'll rush through that. Class 1A, any eye muscle weakness, possible levator palpebrae superioris leading to ptosis, and there is no other evidence of muscle weakness elsewhere. So it is purely levator palpebrae superioris which is being involved, maybe involving one or maybe involving bilateral. Type 2 is eye muscle weakness of any severity plus mild weakness of other muscles, which is divided into A and B, where along with eye muscle, that is levator palpebrae superioris, along with predominantly limb or axial muscle involvement is called 2A, and if it is a bulbar muscle involvement or respiratory muscle involvement, it is called type 2B. Type 3 is eye muscle plus of any severity plus moderate weakness of other muscles, and this moderate weakness is again same, eye muscle plus moderate weakness of limb or axial muscle, and 3B is bulbar muscle and respiratory muscle, but the severity wise it will be moderate weakness, and when it is a severe weakness it will be 4A and 4B, while 5th, where the person will now require intubation and artificial or invasive or non-invasive ventilatory support. So that is grading wise, or depending upon the clinical picture, you classify into 1 to 5, and each from 2 to 4 we call A and B. 2 is moderate, mild, 3 is moderate, and 4 is severe weakness, and 5 where person will require respiratory support. So this will be the simple most way of classifying on clinical grounds. We already mentioned that depending upon the etiology, neonatal, congenital, juvenile, ocular, and generalized. These are the 5 different terminology which are being utilized as far as myasthenia gravis is concerned. Neonatal is a transient condition where you get 10 to 15% of infant born to a mother with myasthenia gravis. There is another terminology utilized as congenital myasthenia. Juvenile will start at around the age of 10 years. Ocular will be localized, which will be involving mainly extraocular muscle and levator palpebrae superiorus, while generalized will involve the extraocular muscle with limb muscles, axial muscles, or may involve even respiratory muscles. So congenital variety is very rare, non-immune forms, and that is inherited as an autosomal recessive disease. Transient neonatal is between 10 to 20% of the babies born to the mother with myasthenia gravis, and which is temporary form of myasthenia gravis. While juvenile is an autoimmune disorder which develops typically in female adult, and it is accounting for 10% of myasthenia cases in juvenile onset. So this particular condition you can come across in children's, that is congenital variety, transient neonatal variety, and juvenile myasthenia gravis. So neonatal and congenital, neonatal mother will be having myasthenia gravis in neonatal variety, while congenital mother is usually not suffering from myasthenia. In neonatal, onset will start after 0 to 3 days postnatal, while congenital will be right from birth up to infancy. In neonatal, it is a generalized weakness, while in a congenital, by and large it is ocular, and sometimes it can be generalized. Remissions will be there for 1 to 6 weeks in neonatal, while in a congenital it is a fix. Antibodies will be detected in a neonatal because it is because of autoimmune mechanism, while in a congenital usually it is because of genetic defect, that is mutation of the gene, hence there is no detection of antibody. This is a simple difference between congenital and neonatal. Among ocular and generalized, in ocular, acetylcholine receptor antibody is detected in 50% of the cases, while in generalized almost in 90% or so. It is the most common finding in generalized, more common than ocular. Hydrophonium test will be more giving results in 70 to 95% for generalized variety, while 60 to 95% in ocular variety. Repetitive nerve stimulation will be more in favor of a generalized myasthenia gravis, where almost right from 50% to 100%, and single fiber gives equal results both for ocular as well as generalized variety. And eyes test will give a wonderful results in ocular variety, where you cannot get good results in case of a generalized myasthenia gravis. So this is one of this. The eyes test is a very beneficial, and another is repetitive nerve stimulation test will be more confirmative for generalized myasthenia gravis, and another is presence of acetylcholine receptor antibody, that will be more positive in case of generalized as compared to ocular variety. Among etiology, one of the most common is thymic tumors, which produces T cell abnormality leading to autoimmune mechanism. There is a second group of disorders which is called Lambert-Eaton syndrome, or LES, where there is an antibody to presynaptic calcium channel. So calcium channel is blocked, so release of acetylcholine is reduced, and that will produce symptoms of myasthenia gravis. And one very big group we call is the idiopathic, where exact mechanism and etiology is not known. Almost 10 to 15% of the cases of myasthenia gravis will come to you with a thymomas, which will be detected very frequently in children's, and 30 to 50% of thymoma are associated with myasthenia gravis. Indirectly, thymoma is one of the common cause for autoimmune mechanism in myasthenia gravis. Also, there will be some drugs like penicillamine will be responsible for exaggeration of symptoms, where acetylcholine antibodies are found in 90% of the patient developing myasthenia gravis, secondary to penicillamine exposure. Hence, penicillamine is one of the drugs which is responsible for development of myasthenia gravis, which will be an acquired group because of development of the acetylcholine receptor antibody, and it is almost found in 90% of the patient where drug induced. There are some precipitating factors like infection, surgery, and drugs. Among drugs, penicillamine comes topmost on the list. Other drugs which can have effect at the level of neuromuscular junction like aminoglycosides, erythromycin, ciprofloxacin, ampicillin, beta blockers, lithium, and magnesium. These are quite common. And among some of the cardiovascular drugs like procainamide, verapamil, we already mentioned here beta blocker. Then quinidine is one of the another drug. Chloroquine will be one drug which is very frequently utilized, and that is also notorious to produce damage to other organs also. Prednisolone, timolol, and certain anticholinergic drugs. Of this, D-penicillamine comes topmost on the list. Other are aminoglycoside, erythromycin, ciprofloxacin, propranolol, lithium, and magnesium. Do not forget those drugs, as well as procainamide, verapamil, and quinidine. We say that almost 85% of the patient will have acetylcholine receptor antibody. There are two other antibodies which are also being established to produce myasthenia gravis is muscle specific kinase antibody, and there is another antibody called as a low density lipoprotein receptor, short form related protein 4, that is LRP4. L for low density lipoprotein, R for receptor, and P for protein 4. So low density lipoprotein receptor is L, R for related, and P4 is related protein 4 deficiency. So low density lipoprotein receptor related protein 4 antibody. So these are the three, out of which acetylcholine receptor antibody, particularly we also mention like nicotinic acetylcholine receptor antibody, which is almost in 85% of the people. Neonatal also, more commonly you will get antibody. It is an autoimmune mechanism seen in an early age group in a neonatal period, while congenital is because of genetic defect where there is no antibody detected. And among drug induced, say particularly in a D-penicillamine, again antibody is detected. But these are the four common terms which are being commonly utilized as far as types of myasthenia gravis is concerned. Epidemiology wise, there is a bimodal episodes, means in woman second and third decade, while in male fifth and sixth decade. So that's why it is labeled as a bimodal. So in female less than 40 years, and almost the ratio to female to male is 2 to 3 times as common than male. So ratio is almost 2:1 or 3:1. While in a male it is seen in a later life, that is between fifth decade and sixth decade. And patient with the thymomas, very commonly they are between 50 to 60 years and more common in males. Pathophysiology, genetic is one of the factor, and other factor is environmental factor, and third factor is immune regulation. So these are the three common mechanisms which will be playing a role as far as pathophysiology is concerned. So in a normal person, whenever there is a stimulus, calcium is released. That calcium gives rise to rupture of this vesicle which is rich in acetylcholine, and acetylcholine is released into neuromuscular junction which will act on an acetylcholine receptor and will depolarize the postsynaptic membrane which is present in muscle, and action potential will be generated. So electrical impulse will be converted into chemical response, and that chemical response after combining with acetylcholine receptor is converted into electrical potential, and this is what is happening in any normal person at neuromuscular junction. So you can see that the person, particularly because of an abnormality in an immune system, the T cells and B cells, that B cells which is converted into plasma cells, they give rise to formation of we call as an antibody against acetylcholine receptor, we call as a nicotinic acid acetylcholine receptor, nicotinic acetylcholine receptor antibody, or it is muscular specific, muscle specific kinase antibody, and they will go and attack the acetylcholine receptor and destroy them, and so impulse will not be transmitted properly to postsynaptic membrane, and this is the mechanism which is playing a role. So thymus gland, there may be thymus hyperplasia, thymomas, there will be T cell abnormality, there will be formation of antibody against acetylcholine, and that will give rise to damage to postsynaptic membrane acetylcholine receptor, and that will diminish the action potential generation. So normal neuromuscular junction, action potential generation, calcium will cause synapse vesicle to rupture, and that will release acetylcholine. Now suppose if the person has got an autoimmune mechanism or thymus abnormality or genetic link, there is a formation of acetylcholine receptor antibody, and this will give rise to reduced neurotransmission. So there will be three mechanisms. Directly it will block the acetylcholine receptor by blocking them, or promotes the endocytosis of acetylcholine resulting into degradation of acetylcholine receptor, and it destroys the number of acetylcholine receptor, hence decrease in neuromuscular transmission, muscle weakness, fatigue, and that is a classical finding in case of a myasthenia gravis, and particularly the muscle which are continuously or repetitively being utilized, and that will give rise to diplopia, ptosis, dysphagia, snarling expression, nasal, that is soft palate paralysis giving rise to nasal speech, proximal limb muscle weakness, and when it is very severe enough, respiratory muscle weakness, and person can have respiratory distress. And this is being explained that because of those antibody, you will have a destruction of the receptor and you will have a diminished response, as well as there is an early destruction of acetylcholine because of those antibody. That is the second mechanism. And third mechanism we have already shown you, that because this number of receptors are being destroyed, and that will also reduce the impulse transmission. Basically it is a type 2 hypersensitivity, and that produces cytotoxic injury mediated by antibody. So there is a formation of antibody by B cells, or we call plasma cells, and these are muscle specific receptor tyrosine kinase antibody, short form we call MUSK antibody, and that will destroy selectively the muscle cells, and it will target the protein in the muscle, while acetylcholine receptor antibody will destroy the acetylcholine receptor. In case of a paraneoplastic syndromes, particularly in bronchogenic carcinoma and thymic carcinoma. You can have formation of a acetylcholine receptor antibody because of abnormal T cell response. So this will be the pathophysiology. We already mentioned the two classical variety clinically, that is Myasthenia gravis and Lambert-Eaton syndrome. Only the pathophysiology is little different. While presentation can be ocular variety or generalized variety. And we have already mentioned the other terminology, that is autoimmune, neonatal, congenital and drug induced. Depending upon the etiology, we have already mentioned that 85% of the time it is autoimmune. Only in 15% of the time it will be due to other pathophysiology. In congenital, it is because of genetic defects, so their autoantibodies are absent, while you will be able to detect the autoantibody in drug-induced, neonatal as well as autoimmune. We have already mentioned this Osserman classification. Class 1, purely ocular muscle weakness, and again in ocular muscle weakness mainly levator palpebrae superiorus. In class 2, mild weakness. Class 3, moderate weakness. Class 4, severe weakness. A is limb and axial involvement. B is oropharyngeal and respiratory muscle involvement. Mild, moderate and severe. And class 5 is where person requires intubation with or without ventilatory support. Maybe invasive or non-invasive mechanism. So prevalence is almost 1 in 7 in 10,000. It affects any age group. Particularly neonatal and congenital are seen in an early age, particularly in neonates and newborns. There is a bimodal peak. In women, it is at an early age, between 20 to 30, and in male, it is 5th and 6th decade. Less than 10% of the time, it occurs in children below 10 years. Ratio is almost 2:1 or 3:1. Sometimes even it is 3:2. Familial occurrence is quite common, but rare. Genetic predisposition is also seen in genetic variety, where you do not get autoantibodies formation. But in a familial variety, you will have a good number of time autoimmune mechanism responsible for that. There can be co-occurrence of myasthenia gravis with multiple sclerosis. Almost in 85% of the time it is a generalized variety. In 15% of the time it is a pure ocular variety. The muscles which are being continuously used, they show the response of weakness and fatigability. So weakness is there on repeated use and it worsens at the end of the day. When the person wakes up, he is fresh. At the end of the day, he feels worse. And after taking a rest and sleep, person improves. Depending upon the disorders, person will have a course of the disease. Initially, it is not complete, not permanent also. Hence, there is a good amount of remissions. Any pathophysiology which precipitates like infection or systemic disorders or treatment, infection and systemic disorders will produce exacerbation, while treatment will produce remissions. But during that treatment, person can develop myasthenia crisis, and within few years of diagnosis, person may not go into remissions, but may develop exacerbation because of infection or other systemic disorders, and may even develop myasthenia crisis. So early in the course, mainly levator palpebrae superiorus and extraocular muscles are more commonly involved. Later on, you start getting weakness of facial muscles, soft palate, and pharyngeal muscles. We call bulbar weakness. And then person can develop intercostal muscle and diaphragm getting involved. Because of involvement of the extraocular muscles and ptosis and diplopia is very common. Because of facial muscle involvement, snarling expression, difficulty in chewing, etc. And when bulbar muscles are involved, dysphagia, nasal speech, nasal regurgitation, aspirations of liquids and foods, etc. And when respiratory muscles are involved, person will find difficulty in breathing and person can require respiratory support. And sometimes person can also require ventilatory support. 15% of the time it is purely ocular, 85% of the time it is generalized variety, where you will have ocular plus facial plus bulbar plus limb and respiratory muscles. And whenever a person, we have already mentioned, when respiratory muscles get involved, person will invariably require respiratory support from outside. And good number of time during treatment, person can develop myasthenia crisis, or because of precipitating factor, person can go into myasthenia crisis, or we also use one word, cholinergic crisis. And whenever the bulbar is being involved, person will start developing dysphagia, difficulty in swallowing, nasal regurgitation, nasal speech, aspiration, all those symptoms because of bulbar muscle involvement. And because of ocular muscle involvement, diplopia, ptosis, and person can also develop squint. So in a generalized variety, almost 80 to 85% of the time, early onset of myasthenia gravis, less than 40 years, more common in female, anti-acetylcholine receptor antibody is positive. Good number of time you detect thymus enlargement, and thymus is abnormal almost in 75% of the person of acetylcholine positive myasthenia gravis, acetylcholine receptor positive myasthenia gravis, and thymus or thymus tumors as a cause of myasthenia gravis is almost common in 10% of the people. Among this 75%, 65% of time it is hyperplasia, and in 10% of the people it may be thymoma, and female and male almost common, and the age of onset particularly in both the groups will be close to 50 years. Whenever it is a late onset, short form it is called LOMG, and early onset is called as a EOMG. Late onset means more than 40 years age group, more common in male, and in those particular group you will have anti-striated muscle antibody positive, short form we call as a MUSK, muscle specific kinase antibodies, and it will produce severe weakness with frequent myasthenia crisis. This is more common with late onset myasthenia gravis. So MUSK antibodies, myasthenia gravis is seen in 10% of the people. It will be seen in a late onset of myasthenia gravis. 40% of the time it is seronegative for anti-acetylcholine receptor is negative, means anti-acetylcholine receptor antibody is negative, so we call seronegative, and it will produce generalized myasthenia gravis. Female are more common than male. Predominantly it will be producing cranial muscle and bulbar muscle involvement. Disease severity, usually it will be going for stage 3 and 4 and 5. It will be going towards those more groups. Muscle atrophy may be seen. There is no improvement, and there is a worsening with acetylcholine inhibitors drugs, and they will give good response to immunosuppressions rather than acetylcholine receptor blockers or acetylcholine esterase inhibitors, acetylcholine esterase inhibitors. And thymic changes are minimal or absent. This particular will be very classical in case of a MuSK antibody myasthenia gravis, or we call as a late onset myasthenia gravis, which is seen in 10% of the group, and it is usually seronegative and severe variety, and they do not respond to acetylcholine inhibitors, acetylcholine esterase inhibitor, and they give better response to immunosuppression drugs. There is one another variety we call as a seronegative myasthenia gravis, which is 10%, where it is negative for both. Anti-MuSK is also negative, and anticholinergic receptor antibody is also negative, and it is accounting for 10%. And myasthenia gravis will be very common if a person develops respiratory failure from myasthenic weakness, and it will measure the respiratory function in myasthenia gravis, where person has got negative inspiratory force. Respiratory assistance is required almost in 20% of the group of people, and commonest cause is intercurrent infections or secondary due to drugs. So triggering factor is very commonly secondary due to infections or metabolic conditions. So clinical presentation is very commonly ophthalmic, which is accounting for 50%, and generalized is 85%. Pure ophthalmic will be ptosis, diplopia, and you might have squint also. While in a generalized variety, depending upon the severity, stage 1, stage 2, stage 3 and stage 4, depending upon that. And particularly we already mentioned here that in this particular group, MuSK antibody myasthenia gravis, it is seronegative as far as acetylcholine receptor antibody is concerned. It is usually a severe variety. There is a muscular atrophy. It does not respond to acetylcholine esterase inhibitor, and they respond very well to immunosuppressions, and it is more of bulbar and cranial muscle weakness. So that particular is more common with that particular groups. And we already mentioned that whenever you get a bulbar muscle involvement, you will have diplopia. This will be with ocular muscle involvement, difficulty in smiling. Facial muscle involvement will produce difficulty in smiling, speaking, swallowing. That will be because of bulbar muscle involvement. Difficulty in raising arm will be because of skeletal muscle involvement of limbs. Difficulty in walking, and when respiratory muscles and diaphragm is involved, difficulty in breathing will be commonly seen. So this will be all the different ways of presentation. The most important part, cardiac muscles are never involved. And peculiar, early morning person is very good. As the day passes, person becomes worse, and when he takes rest and sleep, person improves. So muscle weakness, ptosis, diplopia, fatigue, difficulty in swallowing, the dip tendon reflex are preserved, pupillary reflex is normal, no sensory involvement, generalized muscle weakness in a late stage, asymmetrical pattern, and in a very severe disease, intercostal muscles and diaphragm involved, person will have a respiratory distress, and dip tendon reflex are preserved. And this will be very peculiar in case of myasthenia gravis. Again, same thing explained here. There is one sign, so I would like to mention that is called as a PIC sign. This is due to muscle fatigue. There is a slight improvement in involuntary opening of the eye as the person tries to keep the eyelid closed. So when the person tries to keep the eye closed, there is a slight improvement as far as ptosis is concerned. This is given a name, PIC sign. While all other we have already discussed, ptosis, muscle weakness, wasting, then fatigue, respiratory muscle may be involved, diplopia, nasal regurgitation, food regurgitation, dysphagia, arm weakness, all those we have already discussed. Dip tendon reflex are preserved, no sensory involvement, we already mentioned all those. So ocular muscle weakness, facial muscle weakness, bulbar muscle weakness, limb muscle and respiratory muscle. And classical finding, unequal ptosis. Dip tendon reflex are preserved. So these are the four classical signs, four identifying symptoms of myasthenia gravis. You can see facial muscle involvement, the involvement of skeletal muscles. The person will have even facial muscle involvement, arm muscle involvement, ptosis, etc. We already mentioned all these findings together. At your leisure time, you can go through. This also we have already mentioned. First, earliest finding will be ptosis, diplopia. Then later on, you can have bulbar muscle involvement leading to difficulty in chewing, facial muscle expression, swallowing, talking, etc. And then late stages, respiratory muscle involvement will be there. So ocular will be asymmetrical, ptosis, sustained upward gaze for 30 seconds will produce levatopalpebral weakness, and that will produce ptosis, diplopia. There will be lid twitching sign called as a Kogan sign. So repeated ocular version will be produced because of what we call as a lid twitching sign. Bright sunlight will aggravate the ocular signs and cold will improve them, and pupillary reflex will be absolutely normal, characteristic as far as ocular variety is concerned. And we already mentioned in a bulbar muscle involvement, you will start getting involvement of pharyngeal muscle, soft palate, etc. And if you want to elicit the signs, you will have to ask the person to have repeated blinking, which will produce ptosis. If he produces upward gaze and maintain it for 30 seconds, person will start developing diplopia. Repeated abduction of one limb will produce unilateral weakness of the limb where you are doing an abduction. Good number of time you might have a thymus scar, particularly the person who had thymic pathophysiology, particularly thymic hyperplasia or thymomas, and person has undergone surgery. And he will start showing you also peak flow rate or forced vital capacity will be getting reduced because of involvement of respiratory muscles. So peak sign will be demonstrable. That is, person will have a curtain sign. So enhanced ptosis or paradoxical ptosis is given a name, curtain sign. There is one more sign we have already mentioned, lid twitch sign and peak sign. Due to muscle fatigue, there is a slight involuntary opening of the eye as the patient tries to keep the eye closed. So when he keeps the eye closed, the person will have little involuntary opening of the eye, and that is given a name, curtain sign or peak sign. And we have already mentioned that you can increase the demonstration of this sign by repeated blinking and upward gaze. Here the person will develop ptosis, and when he maintains the upward gaze for more than 30 seconds, you will start getting diplopia. This is a peculiar finding, you can demonstrate that. And when you apply the ice for more than 2 to 3 minutes, you will have improvement in ptosis. This is called ice test. So person will have a diplopia, ptosis. Looking at the feet while lying down on the back for 30 seconds, you will produce diplopia. Keeping the arm stretched for more than 60 seconds will produce limb girdle muscle weakness. Dip tendon reflex will be normal, and when you bend the knee, again you can produce weakness. Walking for 30 steps will also start producing weakness. And we already mentioned the peak sign. After initial opposition of lid margin, they quickly start to separate in 30 seconds, and you will be able to have elevation. This is called peak sign, or also called as curtain sign. So this is very clear. When the person tries to do the upward gaze, he will start developing diplopia. It is also given a name, Simpson signs or Simpson plus, or fatigue or recovery test. And when you maintain it for more than 30 seconds for upward gaze, you will start developing diplopia and ptosis. And maximal lid closure for 10 seconds. Now lid will open, and this is called curtain sign or peak sign. And when you maintain again for 10 seconds, you will start developing again ptosis. You can demonstrate facial muscle weakness good number of times, and bilateral facial muscle weakness. Sclera below the limbus may be exposed due to weak lower eyelid. The muscle facial expression will be nearly absent. So while smiling, person will find difficulty. That's why it is called snarling look. So that is also being seen, and person will have a ptosis, and person will also have diplopia. Upper lip and horizontal contraction of corner of the mouth will produce this typical face appearance while person is smiling. It is what we call as a downward curve of the corner of the mouth, giving a patient sad appearance when the person is trying to smile. This is a typical appearance when you ask the person to smile, and that's why it is given a name, snarling face. Bulbar muscle we already mentioned, nasal speech, nasal regurgitation, aspiration, severe jaw weakness. So person will find difficulty in chewing, difficulty in swallowing, and person can have nasal regurgitation and also can have aspiration of fluids and choking while drinking, etc. And even the neck flexor muscle will be more affected as compared to extensor muscles. So person with those muscle involvement, we call bulbar muscle involvement, will have dysphagia, dysarthria, dysphonia, difficulty in muscle mastications, and also person will have a nasal regurgitation, and because of difficulty in swallowing, person can even aspirates, and there will be risk of choking and aspiration. So chewing will be affected, facial muscle is affected, very common. We call lost smile. When person tries to smile, the facial expression looks like sadness, and that is called snarling face. Limb muscle weakness can be seen because of repeated use, and proximal muscle will be more affected than distal muscle, and good number of time it is an asymmetrical muscle weakness. And this is a peculiar description what is being shown in a limb muscle weakness, and this is upper limb weakness shown in animal. Respiratory muscle may be involved because of intercostal muscle and diaphragm, and person might show respiratory distress, and they might require ventilatory support, maybe invasive or non-invasive. Because of further progress of the disease, external sphincter of bladder and bowel may be involved. Usually the weak muscle do not undergo atrophy, but in a late stage you may see atrophy. Cardiac muscle and smooth muscle are never involved. Tongue may display central and lateral longitudinal furrows. It is called trident tongue. Symptoms may appear first during pregnancy and puerperium and also during anesthesia. And you might see transient neonatal myasthenia in a newborn. There are good number of autoimmune conditions which may coexist with myasthenia, like Hashimoto's thyroiditis or thyrotoxicosis, RA, rheumatoid arthritis, scleroderma, SLE, Sjogren's, mixed connective tissue disorders, polymyositis, etc. You can see here association, hyperthyroidism, quite common in 6%, RA in 2, SLE in 2, diabetes mellitus maybe in 7%, and non-thymus neoplasm. We also use the word paraneoplastic in almost 3%. It is also seen with type 1 diabetes mellitus or demyelinating disease, particularly multiple sclerosis, and also along with other autoimmune disorders. During the course, you can get myasthenia gravis, myasthenia crisis, where person gets severe muscle weakness, inability to swallow, and muscular paralysis. And sometimes, because of no response during routine therapy, person may develop refractory crisis. Similar type of the symptoms during treatment because of unresponsiveness. Usually we use the word refractory crisis. And there is another variety we call as a cholinergic crisis, which is because of excessive cholinergic medications, which will lead to nausea, vomiting, muscle weakness, abdominal pain, and diarrhea. This is because of excessive anticholinergic drugs, or we call acetylcholine esterase inhibitor drugs, excessive dose, which will produce cholinergic crisis leading to nausea, vomiting, muscle weakness, abdominal pain, and diarrhea. While refractory crisis, because of diminished response during therapy, person will have a refractory and no response or diminished response, that is called refractory crisis. And during a course, if a person develops infections or there is some precipitating factors, severe infections, etc., can produce sudden severe muscular weakness, bulbar involvement, and respiratory muscle involvement, that is labeled as myasthenia crisis. So myasthenia crisis is rapid and severe deterioration of myasthenia findings, called as myasthenia crisis, which is going to have sudden weakness, severe weakness, bulbar muscle weakness, and respiratory muscle involvement. And good number of time person can have even quadruparesis in few hours. Commonest cause is respiratory infections or by some drugs which will block neuromuscular junction, like streptomycin, erythromycin, quinidine, etc. It can develop at any time after the diagnosis of myasthenia, and it will require respiratory supports. Disorders which worsens the myasthenia gravis, like fatigue, viral infection, severe stress or emotional stress, extreme heat, hypothyroidism, and drugs like beta blockers, quinine or quinidine, and CCB, and some of the antibiotic, particularly erythromycin, streptomycin. Do not forget those drugs. And we have already mentioned emotional stress, viral infections, hypothyroidism, pregnancy, exposure to extreme heat, and some of the drugs. During pregnancy, preeclampsia, hydroamnios, prolonged second stage, increase during cesarean section, fetal causes, intrauterine growth retardation, miscarriage, stillbirth, Neonatal myasthenia gravis will be quite common in these groups. So, effect of myasthenia gravis on pregnancy can have complication during pregnancy like preeclampsia, hydroamnios, prolonged second labor, and increased chance of cesarean section, while fetal complication like intrauterine growth retardation, then I don't know this, miscarriage, stillbirth, and neonatal myasthenia gravis almost in 10 to 20% of the time. We already mentioned that sensory system and deep tendon reflex will be absolutely normal. Muscle strength will be reduced in the muscle which is being affected. And if the person has got intercostal muscles and diaphragm being involved, person will have a difficulty in breathing. Drugs like D-penicillamine, quinidine, procainamide, quinine, aminoglycosides, beta blocker, CCB, magnesium, etc. can precipitate myasthenia crisis and can also produce myasthenia gravis. Some of the disorders may interfere with the therapy like tuberculosis, diabetes, peptic ulcer, GI bleeding, renal disorders, hypertension, asthma, osteoporosis, obesity, etc. can interfere with the treatment in myasthenia gravis. Usually, if we want to differentiate between myopathy and myasthenia, particularly if we take as ptosis, in myasthenia it is asymmetrical, while in myopathy it is symmetrical. Ptosis is usually produced on fatigue in myasthenia, while there is no precipitation of ptosis on fatigue. Lid twitch will be seen in myasthenia. Recovery with eye closure will be again in myasthenia. We call pick sign or curtain sign, etc. Range of levator function will vary from time to time, while in case of myasthenia it will be constant. There will be not much amount of worsening or not much amount of improvement. There will be also weak orbicularis oculi in both in myasthenia as well as myopathy. Tensilone test will be positive in myasthenia. Strong family history will be more common in case of myopathy. In very few cases we will have a strong family history, so it is rare. And course, as far as myopathy is concerned, it is slowly progressive, while in case of myasthenia it is fluctuating, and you can trigger of myasthenia crisis, cholinergic crisis, etc. during the course of myasthenia. Also, you can come across resistance crisis. There is one differential diagnosis you will have to differentiate, that is Lambert myasthenia syndromes, which is a presynaptic disorders where ptosis is seen in 40% of the group of people, and there is a decrease or absent reflexes. You might have autonomic features may be present, usually associated with small cell carcinoma of lung. So it is good number of times seen as a paraneoplastic syndromes. And the treatment as far as little Lambert is concerned, plasmapheresis is an immunosuppressant, is a drug of choice. And pyridostigmine use can prolong acetylcholine action, and hence this may be also beneficial in a person with Lambert-Eaton myasthenia gravis or myasthenia syndrome. It is a presynaptic disorders where antibody is against the calcium channel in a presynaptic nerve ending, and it is almost positive in 85% of the group of people. There is an impaired release of acetylcholine from a nerve terminal, and there is something called as a warming phenomena. Proximal muscle are more involved as compared to distal, and cranial nerve involvement may be seen, or cranial muscle involvement will be seen in almost 70% of the time. You will have a diminished or absent reflexes. autonomic findings will be there, and you will have what we call as a incremental response to RNS, and there will be warming up phenomena, and quite common as a paraneoplastic syndrome. We already mentioned treatment, immunosuppression, and plasmapheresis is the first line of treatment. As far as investigation is concerned, first again clinical examination and physical examination is very important. Among blood tests, demonstration of receptors antibody. So we call nicotinic acetylcholine receptor antibody will be present in almost 85% of the time. MuSK antibody will be present in 10%, and LRP4 antibody will be present in less than 5% of the people. You can do hydrophonium test, you can go for ice test, etc. Pulmonary function test will be required to find out the severity of the respiratory muscle involvement. Imaging study will be mainly useful to rule out thymic tumors and thymic enlargement. EMG, single muscle fiber, repetitive stimulation, nerve conduction study, muscle biopsy. This will be useful to rule out other differential diagnosis like peripheral neuropathy, myopathy, etc. And we have already mentioned acetylcholine receptor antibody and anti-MuSK antibody will be present in almost 95%, and LRP4 antibody will be in less than 5%. And you can go for Tensilone test. Tensilone test, or we also call as a Hydrophonium test. These are the two different tests which you can go for, which will show you improvement in a person with Myasthenia Gravis. So Tensilone test, ice pack test, sleep test, and fatigue test. These are the tests which will show you improvement or worsening of the symptoms and signs, which will be favoring Myasthenia Gravis. And as far as we have told you, some of the investigation, particularly antibody test, EMG, and radiology. So genetic study will be required if you are suspecting genetic etiology or genetic variety of Myasthenia Gravis. EMG, we have already told you, it will help you to differentiate myopathy from Myasthenia Gravis, and muscle biopsy will be also useful to rule out myopathy from Myasthenia Gravis. We already told you antibody, that is acetylcholine receptor, in almost 85%, anti-MuSK almost in, we say that it may be present in 10% of the people, but sometime in a seronegative it is called, it is purely 10% of the group, but along with seronegative of acetylcholine receptor antibody may be seen also in 5% of the people. So you have to find out which variety it belongs to. And then we have told you EMG study, repetitive nerve stimulation is one variety where you have to stop anti-acetylcholine esterase medication at least 6 to 24 hours before doing this test, and big muscle or proximal muscle is being tested. You have to give a repetitive nerve stimulation for 2 to 3 seconds, and you look for the EMG changes. In Myasthenia Gravis, 10 to 15% decrease is in favor of Myasthenia Gravis. And you can go for hydrophonium test, which will show you improvement after giving hydrophonium. This is hydrophonium test, which first initially, this is an cholinesterase inhibitor. It will be more specific for a person who are having anti-acetylcholine receptor antibody. EMG will be useful, pulmonary function test will be useful, CT or MRI will be useful to rule out Thymomas, and you can screen for all other autoimmune disorders which are very frequently associated with myasthenia gravis. Radiology mainly for ruling out thymic tumors and thymomas. Tensilone test, initially you give 2 milligram of hydrophonium and then you can repeat the remainder dose of 8 milligram totally up to 10 milligram. But only experts should perform this, and then you can find out whether it is a negative response. Atropine should be always available during the test to counteract the bradycardia. So this should be done only in specialized center only. Never try to do this particular test in your clinic. So after hydrophonium test, you can see there is an improvement in the ptosis part. So we call that a hydrophonium test has produced positive response. And so this is more in favor of myasthenia gravis. There is an ice pack test where you keep an ice pack for 3 to 15 minutes, and after that sometimes you give a rest for 30 minutes. The ptosis will improve. If it improves, it is associated with myasthenia gravis. So this is called ice pack test. Then we have already mentioned to you regarding EMG. Single fiber repetitive stimulation will show you a typical changes. So single muscle fiber testing will show you greater sensitivity, and that is more informative. Will show you somewhat like atrial fibrillation. So repetitive stimulation will be very specific for generalized variety rather than ocular variety. And single fiber EMG will be again very informative in generalized variety, and 90% of the time it will be also useful in ocular variety. So repetitive nerve stimulation, short form we call as RNS, will be more informative in generalized, and single fiber EMG will be useful in both, but more for generalized than ocular variety. Sleep test, if the person goes to sleep for half an hour to 1 hour, there will be improvement in the symptoms, but it is difficult to perform at the clinic, but person can give you an idea regarding this, and you can still do this test in your clinic also. There is something called as a fatigue testing, where you ask the person to blink or maintain the upward gaze, and then you will demonstrate ptosis as well as diplopia. So sustained upward gaze, eyelid fatigability, and holding the ptosic eyelid up, all this can demonstrate a fatigue in a muscle which you are constantly using. Differential diagnosis wise, you will have to differentiate from neuropathy, myopathy, Lambert-Eaton syndrome, etc. Lambert-Eaton myasthenic syndrome. Also, you will have to look for Guillain-Barré, other like botulism, neurasthenia, those groups. As far as management is concerned, we call cholinesterase inhibitor are the most commonly drug being utilized, like pyridostigmine and neostigmine. Immunosuppression will be very, very helpful in a person with anti-MuSC antibody variety of myasthenia gravis, where prednisolone, cyclosporine and azathioprine are commonly being utilized. If the person has got thymic tumors, thymectomy may be helpful. The other way of therapy which is being tried is IV immunoglobulins and plasmapheresis. Also, there is now drugs like monoclonal antibody against B cell and C5. These are being utilized along with other treatment. So main goals are control of symptoms, maintain functional ability by physiotherapy, occupational therapy and speech therapy, and you prevent the complications like cholinergic crisis, myasthenia crisis, respiratory distress, aspiration complications, and malnutrition. Our main goal should be all this. So some of these are for maintaining your functional ability and control of symptoms. But simultaneously, you must look for cholinergic crisis. Don't overtreat with anticholinergic drugs, or we call choline esterase inhibitors, that is likely to produce cholinergic crisis. Myasthenia crisis can be precipitated by infection, so immediately person should be treated. So precipitating factors should be controlled as early as possible. And then you can treat with what we call as a plasmapheresis or IV immunoglobulins or immunosuppressions. And if the person has got thymus, you can go for thymectomy. And if the person develops respiratory distress, you can go for respiratory support. Prevention of aspiration pneumonia and maintain nutrition will be the prime goal. So non-immune therapy is what we call as cholinesterase inhibitors. Short-term therapy as plasmapheresis and IV immunoglobulins. Long-term therapy, steroids, immunosuppressions, and thymectomy. So these are some of the modes of treatment which are being advised in myasthenia gravis. This is one chart you can go through where it is being explained what you do in a crisis, what you do if it is generalized variety, what you do in an ocular variety. If it is ocular variety, mainly anticholine esterase inhibitors are being utilized. In generalized variety, initially anticholine esterase is being used. You can go for thymectomy. If there is a good results, etc. And if person doesn't get improvement, and if the person doesn't improve even after thymectomy, you will have to go for immunosuppressions. And if person has already developed, we call as myasthenia crisis, person will require respiratory supports, IV fluids, plasmapheresis, IV immunoglobulins, and may require later on immunosuppressions. Same thing is shown here. You can go through your at leisure time. So during myasthenia crisis, severe complication can be life-threatening, acute worsening, respiratory failure. Invariably, person will require non-invasive ventilation or invasive ventilation like BiPAP. BiPAP will be non-invasive. Person might require intubation and invasive ventilations. And then person might require immunoglobulins, plasma exchange followed by immunosuppressions. Some of the drugs you will have to avoid like streptomycin, ciprofloxacillin groups, then propranolol or beta blockers, quinine, magnesium, penicillamine, local anesthetics, erythromycin. Do not forget these drugs, particularly if the person is having myasthenia gravis. These are some of the acetylcholinesterase inhibitor, particularly pyridostigmine and neostigmine. At your leisure time, indications, side effects, interactions, and contraindications. At your leisure time, you can go through. There is no response or worsening if the person is having anti-MuSK positive myasthenia gravis. So these are not to be given in a person with anti-MuSK positive myasthenia gravis. But before utilizing these slides, do consult expert. Among immunosuppression, glucocorticoids and other drugs like azathioprine, cyclosporine, etc. or cyclophosphamide are very frequently, and cyclophosphamide is good number of time in a refractory cases. Even plasmapheresis mainly in a myasthenia crisis, and immunoglobulin therapy right from 4 gram per kilogram per day for 5 days it is being given, and you can go for even pulse therapy with methylprednisolone is a common utilized in myasthenia crisis or before doing any particular surgery which is required in a person with myasthenia. This is use of glucocorticoid at your leisure time. Again, indications, side effects, interactions, and contraindications. At your leisure time, you can go through. This is regarding immunoglobulins. Indications, side effects, potential interactions, and contraindications. I am not going in detail. Plasmapheresis, every day, almost 6 sessions. Improvement will be starting after 1 week of treatment, but it is expensive. Improvement may last for 1 to 2 months, and later on person may require immunosuppression drugs, etc. There are some immunomodulatory therapy for long term like thymectomy to induce remissions, and immunomodulatory drugs may be also utilized for inducing remissions. And thymectomy now good number of time is done by endoscopic surgery or minimal invasive surgery. And the main indication is Thymomas, and particularly in a generalized myasthenia gravis who are seropositive, we call anticholine receptor, anticholinesterase receptor, antibody positive generalized myasthenia gravis. Open surgery days are gone. Complete remissions without any medications can be achieved. With medications, particularly immunosuppression, glucocorticoids, anticholinesterase, or combination of 1, 2, 3 both together, you can achieve. Improvement you can get depending upon good improvement or moderate improvement, or person may not get improvement at all, or person may become worse, and sometimes person can also die during treatment. Yoga exercise may also help to improve in some of the people. Good nutritious diet will be also helpful. As far as complication is concerned, aspiration pneumonia, respiratory distress, particularly we call as myasthenia crisis. You can come across cholinergic crisis during excessive treatment with cholinesterase inhibitors, and sometimes you can come across what we call as a resistance crisis because of decreased effect of the drugs. And aspiration pneumonia complications will be very common when the person develops bulbar involvement. And when the person gets myasthenia crisis, the chances of respiratory failure will be very, very high. Second to these particular complications, person can develop complication because of treatment itself, like long-term use of steroids, immunosuppression drugs, immunoglobulin therapies, etc. So there will be very high chance of getting opportunistic infections, all those things in a person with steroid use and complication of long-term steroidal use. So good number of times sepsis quite common because of use of immunosuppression, steroids, etc. Renal failure because of IV globulins, cyclosporine, and we already mentioned long-term complications because of steroid, and overuse or excessive dose of cholinesterase inhibitor can produce cholinergic crisis. So I end my lecture here. Thank you very much for taking out time. I know that your time is valuable. I know that you have spent some of the time with me, and I appreciate that you have spent some of the time with me. If you feel this lecture is helpful to you, don't forget to press button like, subscribe, press bell icon, and you can share with your friends. See you in next lecture.